Hello, everybody. Welcome to the Totally Well Show. I'm your host, Joyce Strong. The Totally Well Show is a place where we get curious, ask questions, and explore everything to do with health, wellness, fitness, personal development, helping people, and all the things it takes to help you live a strong, joyous life. I am back again with my guest, Dr. Sailaja Reddy.
Hi, Joyce.
Hi, nice to see you again. Dr. Saila is a functional medicine practitioner, and her website is RootHealthMD.com, and also on Facebook we can reach you at RootHealthMD. So traditionally you've been an internal...
I have been an internist, practiced internal medicine for more than 20 years. Recently, I got certified in integrative and functional medicine. I developed special interest and I'm enjoying it a lot. So I'm now practicing functional and integrative medicine.
Wonderful. Can you tell me a little bit about what functional medicine is?
Functional medicine is an approach to health and wellness that focuses mainly on identifying the underlying root causes of the disease rather than treating isolated set of symptoms. We do a lot of advanced testing to find the root causes, which is not done in the traditional medicine.
So you still have the ability to prescribe medications if sometimes somebody needs that
we have the ability to prescribe the medication, but the goal is to de-prescribe the medication and fix the lifestyle, diet, and exercises and supplements. So a lot of times we are able to reverse the chronic conditions just by this, even though initially we give the medications, but the goal is to transition.
Yeah. So is lifestyle medicine a good nickname for it?
Not really, because I took some lifestyle medicine courses in Harvard, but this is slightly different. Functional medicine is a systems biology approach. This is evidence-based medicine.
Got it, okay.
So you create personalized treatments in functional medicine.
So lifestyle is more like
lifestyle medicine, they don't look at the root causes. That's functional medicine is specifically the one that looks at the root causes.
Got it.
And the lifestyle medicine, I don't think they do this advanced testing.
Okay.
We have the cutting edge resources in functional medicine.
Yeah, it's interesting because I often use some of those terms, functional, integrative, lifestyle, holistic, all as one term, but there are differences.
There are different. Holistic medicine is when you're doing non-conventional medicine in place of conventional medicine. And the alternative you are doing in addition to conventional medicine. Integrative also, you focus more on the mind, body, and spirit rather than addressing only the physical aspect of the health.
Yeah.
So, and integrative medicine uses a lot of non-conventional methods, wide variety of techniques like acupuncture, Ayurveda, like aromatherapies, yoga, and all these things. But it is not always evidence-based medicine, but functional medicine is evidence-based.
Yeah. Well, I'm glad that you clarified that for me because I'll be more careful about what I use for the right terms. I wanted to talk with you today about, I know you have a special interest in gut health, and I wanted to maybe get a idea of when we're talking about gut, what the actual anatomy is that we're talking about, and things like typical conditions that people talk to me about as a coach, often SIBO or irritable bowel or that they're just not right there. Diarrhea, constipation, like some symptoms they usually come in with reflux.
Gut is actually my special interest. I have treated a lot of patients, even when I was practicing mainstream medicine. People used to come to me just for the gut health, actually. Even my colleagues used to refer patients when they have gastrointestinal conditions because not everything needed to be treated by the GI specialist. There's a lot of functional role in the gut health. Let me explain you what gut is. Basically, it is a gastrointestinal tract. It is a long pipe that we have. When you eat the food, it goes down the throat, which is actually esophagus. And from the esophagus, the gut leads to stomach. Between the esophagus and your stomach, there is a valve that lets the food go into the stomach. But if that opens up in the wrong direction because of the bacteria in the stomach or because of the undigested food due to lack of hydrochloric acid and all, the gas forms and it lets the not only the acid and all the stomach contents leak back into the esophagus. Because the esophageal lining is not meant to take the acid, so you develop heartburn, inflammation there. And what you do is give the acid blocking medications, which is not a right thing to do, which we can talk later. And then from the stomach, it goes to the duodenum, it's a small intestine, ileum, and then to the large intestine. Small intestine is a place where your food is digested and absorbed.
Okay.
And from there, the fiber goes to the large intestine. In the large intestine, the fiber is the food for the bacteria. So depending on how much fiber and what type of fiber you're giving, the bacteria eats the fiber and gives you good substances called, short chain fatty acids and all that for your colon lining. Those things keep your colon lining healthy.
Okay, so that fiber is important.
It's very important.
Feed the healthy bacteria in the large intestine.
Right. There are two different kinds of fibers, soluble and insoluble fiber. Each one has its own roles, but soluble is much more useful. But insoluble fiber is like a broom in the intestine, it cleans up. You can't put your hand and clean the intestine, right? So that's what Mother Nature designed it for, cleaning.
But soluble fiber does something different?
Soluble fiber is different, but most of the food that we eat contains both soluble and insoluble fiber. The soluble fiber feeds bacteria, and there's a lot of other things soluble fiber does it for.
Got it.
Yeah. Insoluble is more like a bulk forming thing for you to move the stool.
Okay. So on to some of the deeper discussion or more technical stuff of maybe we can start with the reflux of what happens with...
The reflux is basically, it's irritation of your esophageal lining, right? Because the acid is very strong for the lining to take unless it is designed for the acid, which is the stomach lining. Stomach lining is designed for the acid. So what happens when your food goes into the stomach? It needs to be digested, right? So the body produces the stomach lining produces hydrochloric acid that is required for the digestion of the food. So as you get older, you don't produce that much acid. With the age, it goes down, and a lot of other factors. Nowadays, people take the acid blocking medications also. So acid is such an important thing for your digestion. If you take those medications, which are given in fact to decrease the acid reflux, which actually I don't agree with it completely, then undigested food, you accumulate more bacteria, the gas pushes the esophageal sphincter back in the wrong direction. So the contents, the stomach leaks back into the esophagus and irritates the lining there. Then you get the burning pain, heartburn, you call it. So the real treatment is initially when you have a heartburn, of course, you have to take the acid blocking medications. Then you don't want to take it for years, because a lot of patients come to me with those medications they have had for several years. And because they're not good, you need the acid for the digestion, right? So the goal is
the acid blocker was there to treat the symptom initially, to take you out of pain.
Right, but not in the long run. So I usually don't keep, if I start those medications, I don't keep it for more than 2 to 3 months. Then you have to educate the patient on the lifestyle. You have to eat good. If you eat all the fast food, then you're going to have problems with the digestion, and you accumulate bad bacteria. And some people, it's not just the type of food. Some cannot accept certain foods. A lot of people have the dairy intolerance. So those people, if they take dairy, when they have dairy intolerance, it could create other problems too, like SIBO and stomach issues and heartburn. Even extra gastrointestinal issues like acne and all that can come too. So it's what you eat that matters. And you have to, if you have more allergies, then you have to get the food sensitivity testing. That's a whole different show we can do on that.
Yeah. Well, so a lot of things are going on, but the big message is if you are on some type of a proton pump inhibitor or acid blocking medication.
So sometimes I get patients just for the reason to de-prescribe, acid blocking medications, which actually take some time, because we have to look at the amount of gastrin they have inside, and we have to slowly take it off if they had been on many years. So that they require actually functional medicine specialists to go. We have a long protocol on how to do that.
Yeah, which explains why when people have so much trouble getting off, because they immediately get the symptoms back.
Right, immediate, yes, rebound hyperacidity.
Yeah, so by working with you in
a slow fashion,
in a protocol that you know works, then they can eventually.
A lot of supplements we use for that.
Yeah. So what are some of the other conditions that people, besides the acid reflux?
The most common condition people come to see me is for bloating symptoms and indigestion. These are the chronic symptoms. Actually, interestingly, I had a patient who has had like this bloating for almost 10 years in her life. So she came to me without any expectation that I was going to cure it, but she said, I want to visit my daughter who is far away, and I just want to have some pain relief for a few days so I could sit in the flight. She was like so sick and she couldn't even travel.
Yeah.
And I said, okay, you need to, I need to do some testing. I did the testing and I started the supplements. Believe it or not, within a day, her pain was gone.
Oh, wow. She
was like so thrilled, and I said, I totally didn't expect this, It was just a natural antibiotics that I started her on. There was like so many bacteria sitting in her small intestine. Once you treat those bacteria with the natural antibiotics, you get such a huge relief.
When you say natural antibiotics, what are you talking about?
Oh, there are like combination of antibiotics. When you have a small intestinal bacterial overgrowth, there are several different antibiotics that you could choose from. But you don't just give one antibiotic like you do in mainstream medicine. If you take conventional medicine, you just give one antibiotic, right? Here you go with a combination antibiotics, like usually oregano, berberine, neem, and all this. There are antibiotics that come in combination also. Like a Candibactin, AR and BR, and all these things come in combination.
So these are herbal-based?
Herbal-based.
Got it.
Yeah.
But they are also evidence-based.
Yes, it's evidence-based antibiotics.
Yeah.
In my experience, they have less side effects than the conventional antibiotics that we use for SIBO. But it's a long course, like 4 to 6 weeks. But the traditional antibiotics, like Xifaxan and neomycin, you use them only for 2 weeks or 4 weeks, depending on the combination.
So one of the medication antibiotics might wipe everything out, whereas does a natural antibiotic do that as well?
Traditional antibiotics tend to wipe out more bacteria than the herbal antibiotics.
Yeah.
Herbal antibiotics, they are also antibiotics, right? So I'm not going to say that they don't, but they do. Yeah. They even wipe out some good bacteria, but not to the extent the broad spectrum antibiotics wipe out your gut.
And it's a good idea to see someone like you who has certain protocols or knows how to combine, because I often see people try to DIY it, do it yourself.
No, you can't do that.
They can overdose.
Because we have to even look at the lactulose breath test, which tells exactly what type of bacteria they have. There are 2 different kinds of bad bacteria, more than 2 in fact, but the common ones are 2. So depending on the type of bacteria you have, the treatment changes. For example,
are you talking about for SIBO?
SIBO.
Okay, can you define SIBO?
SIBO is a small intestinal bacterial overgrowth. The small intestine is a place where you're not supposed to have too many bacteria, maybe a small amount will be there.
How do they get there?
Yeah, I'll come to that. So when you have more bacteria, the exact count is more than 105 CFUs per ml. It's called SIBO. There are several factors that you get the bacteria there. The first thing that we already talked, it's like lack of acid. Because acid, Mother Nature designed to flush out the bacteria in the small intestine. Okay. So we have something called migratory motor complexes, which means they're called cleansing waves. So if your cleansing waves are not strong enough to clean the gut, then you get the SIBO.
Okay.
Then if there is an ileocecal valve, so if for any reason there is a dysfunction of the ileocecal valve, which is supposed to block the bacteria from the small intestine, from the large intestine coming back. So if there is any defect in the valve, the bacteria in the large intestine can leak back.
Could that be caused by inflammation or?
Oh, several factors, but that's not actually the common cause anyway. But the common causes are like a low acid and the pancreatic enzyme deficiencies. So the enzymes are necessary for the food digestion. If you have the deficiencies of the enzymes, then undigested food creates inflammation there, and you develop leaky gut, and then
what can make you have deficiencies in pancreas?
Yeah. It could be any causes like exocrine and endocrine pancreas we call. If it is an endocrine deficiency, then you get diabetes because your insulin is not produced. Exocrine deficiency is lack of enzymes. Actually, as you get older also, every enzyme in the body slows down with the age. Or there could be some nutrient deficiencies also that can,
so you might in a particular person like my age recommend enzymes just because of my age if I had symptoms?
What I do is I do the stool testing. The stool testing gives you an idea of what their enzyme balance is there because we look at the elastase and all in the stool.
This is something your regular doctor would be doing.
No, regular doctors don't do it. It's called comprehensive stool evaluation.
Okay.
So that gives a lot of information like what type of bacteria you have and what is your enzyme activity, and there's a lot of substances that the bacteria produce. We can look at all those substances there.
Okay.
It's a very interesting test.
So when it comes to the treatment, you can be very specific.
Right, exactly. We can personalize the treatments. It's not the same treatment for every patient, so you cannot do it yourself. You have to go to see the doctor.
Yeah. I love that personalized treatment. Everybody is a unique recipe or unique. I mean, you'll have a protocol to use, but you're going to personalize it for that.
Yes, exactly.
Yeah. So we defined the reflux and how we need acid. We defined SIBO. What are some of the other, like, can you tell me what often the sort of a garbage can term, irritable bowel, like when you don't know what to call it irritable bowel.
Yes, that's another common cause I get the patients.
Yeah.
But 60% of the patients with the IBS, which is irritable bowel syndrome, have SIBO.
Oh, really?
Actually, yeah. Once you treat the SIBO, you treat the IBS.
Okay.
Like the other 40%, I would say, like a food sensitivities. So I look at the food sensitivity testing. I look at the SIBO testing, which is the lactulose breath test.
Yeah.
And I look at the GI effects test, the stool test. With all this information that I get from these three tests, most of the time I could fix the IBS actually.
Yeah.
I mean, at least make the symptoms get better. I mean, not everybody can reverse the symptoms, but most of the time we could.
So but beyond the testing piece of it, what do you do first? What's the first intervention typically?
It depends to what extent the patient wants the evaluation done. Some patients come and say, I can't even pay a penny for the test, Then I have to do the guesswork. Then I'll give like a dairy-free diet and gluten-free diet and all that. Okay. If they say, okay, do all the workup you can, I would like to fix it. Then I do the gluten testing, stool testing, breath testing. Then I get a lot more information to personalize the treatments. Otherwise, I have to give a general advice, like, okay, go gluten-free, do the elimination diet, and see, how you feel when you reintroduce the food.
So it takes a lot longer without the testing.
Yeah, it is.
That's good to know.
Yeah.
And I think sometimes, depending on the person's insurance, the insurance may cover some of this.
Most of them, their insurance. It depends on what type of insurance they have.
Yeah.
It's interesting. Sometimes, the insurance, the same insurance also, patients come back and say, oh, I had to pay money, the insurance didn't cover it. But I give the same indication to the insurances, I have to.
But they can call ahead and ask their insurance or appeals. I think that's another way to do it. But it's definitely worth exploring it.
It is worth exploring.
Yeah, I know a lot of times.
Because it's a life-changing thing if we could fix the problem.
Imagine, I know, yeah.
And especially for this patient I told you who was suffering for 10 years and the pain was gone in a day, she was just thrilled.
It's amazing. And just look at the impact it has on your life if you just kind of chronically live with these symptoms that we think we have it, that my mother had it, And
the other thing I want to mention with the SIBO is like if the patients do it by themselves, there's a high rate of recurrence.
Okay.
When it comes back, the antibiotics we choose could be slightly different. So the patients won't be able to manage it on their own.
Oh yeah, they'll say,
when the
"Oh, I
recurrence
had it
come.
before," so they'll treat it the same way.
It's something that must be treated by a physician.
Yeah. So one of the terms that you use, and I've heard used, is FODMAP diet. And is that something that people use related to SIBO?
Yeah, they could use the FODMAP diet because, in fact, some patients do it for the diagnostic purpose also before they even come to see the doctors, for the educated patients, knowledgeable patients on this.
But there's a lot on the internet, and people
there's a lot on the internet. There's a lot of good apps also on the iPhone.
Yeah.
The FODMAP itself is an app.
Okay.
And there's several apps that they could use. And if you don't want to treat with antibiotics, and if you just want to treat the patient on the FODMAP diet, it even takes about 2 years for you to get rid of the SIBO.
No wonder people give up long before that. Can you define FODMAP for us?
It's a fermented oligo, di, and monosaccharides and polyols. Okay, these FODMAPs, the bacteria uses them and produce gas when they eat the FODMAPs. So in the FODMAP diet, you give the diet with the low FODMAPs. So for example, like onions, garlic, and they're all high in FODMAPs. So we don't want patients to eat them. So especially in the Indian cooking, we use a lot of onions and garlic,
Yeah.
So it's difficult for people.
Do you have to eliminate them completely even
because
a little
the
bit?
FODMAPs, in the app, they say the green items, orange items, and red items.
Okay.
The onions and garlic are in red. So the green you can eat, but orange, it depends on your SIBO symptoms. If you have high symptoms and if you have a high bacterial count, I would just avoid even the medium items also, which are like avocados and stuff,
Can you ever go back to eating those foods after
you've
resolved?
Yeah. After you resolve the SIBO and once you fix the lining, then you can go back to these foods.
Yeah.
But I would say like the onions and garlic, things like that, which are very high in FODMAPs, you have to
I know my two
probably
favorites.
cut down a little bit all your life.
Yeah. Oh, okay. So you may still be able to have some, but not to the extent.
But not to the.
But that wasn't necessarily what caused it, right? Those foods?
That's not what caused it. But once you have the bacteria, you don't want to feed the bacteria because you're growing the bacteria.
Yeah.
Even though it didn't cause it, that could make it worse.
Got it. Yeah, that's confusing for people because they think forever. Like anytime they have a symptom, they think this is forever or I inherited this. But these are not.
No, this is not forever. But again, it depends on the cause of the SIBO. So if you're elderly, diabetic, because your gut is not moving, another thing that I didn't mention is when you have diabetes, you have like gastroparesis and those cleansing waves are not as strong.
Okay.
So you get the SIBO. That's a high recurrence rate because they have the diabetes. Unless they cure the diabetes, they're going to have recurrent SIBO. So
I didn't know that. So you have your what do you call peristaltic waves?
It's migratory motor complexes. You can call them cleansing waves.
Okay, cleansing waves. They don't work as well when you have diabetes.
Yeah, because of the slow gastroparesis usually is common in patients with long-standing diabetes.
Okay, yeah.
Yeah, that's interesting. But I tell like if it is even before the SIBO recurs, I tell them like to use the motility agents. Like if you take them like before they go to bed, that improves your cleansing.
Like what?
You can use it either as supplements or as a natural things. Like the natural ones are like a ginger. If you take ginger and a little bit of apple cider vinegar and ginger every night or in the morning, that improves your cleansing waves. Okay. And the supplements are like Motil Pro, and there's several different.
What was the last one you said?
Motil Pro. Motil Pro is a supplement that helps with the motility of the gut.
Yeah. Are things like magnesium helpful for the gut?
Yeah, magnesium is helpful to loosen up the stools a little bit, but it's not a great motility agent.
Okay.
Yeah.
So those are. It's interesting because when people come in with, they'll go between diarrhea and constipation. They're often a presenting symptom, right?
For the IBS.
And then being able to say, well, this works because of this reason, and so you might do more than one thing.
Yeah, for that actually, you need to see what foods are giving the symptoms for IBS.
Yeah.
And you need to see whether they have SIBO or not. because unless you fix these root causes, you won't be able to treat the IBS.
Yeah. And so back to the original presenting, if a person says they have bloat, they could have bloat all the way through, right? Not just the SIBO and also in there.
No, it is the small intestine is the problem mainly.
Okay.
If they bloat in the large intestine can expand a lot, but that's a place where the bacteria are there anyway, so you don't have that much of a symptom in the large intestine bloating. It's a small intestine that bloats and give you the symptoms because small intestine is not designed to expand like large intestine.
Okay. Oh, that helps a lot to understand because I often think of it as, so if somebody has gas and flatulence, is that small intestine or large intestine?
That could be both. Because when I do the stool testing, whatever I find in the breath testing in small intestine, I see it in the stool testing as well because it is going down the pipe.
Yeah. Wow. Very comprehensive. Yeah, you do so much.
It's difficult to explain it all in 20-minute show.
Yeah, well, I told you we're about out of time, but we wouldn't be able to cover everything today. But I just wanted to give people a little bit of a hint about how different the treatment is and the approach is when you're in functional medicine, and how your unique skill set of having the traditional training and then this very evidence-based comprehensive training on top, and then the different kind of care that they'll get with just the amount of time they spend. So anything else you want to add before we wrap up with this show?
I think we pretty much covered everything in the
we did
GI tract.
We did a good, I mean, there's a lot to learn, but hopefully people will feel free to reach out to Dr. Sailaja Reddy, and again, RootHealthMD, and on Facebook,
Framingham.
and RootHealthMD.com on the website. Your office in Framingham, and also you can work with people in Massachusetts remotely, so you don't have to necessarily go to Framingham.
But they have to come for one initial visit, though.
Right.
And the follow-up visits could be in the remote setting.
And remote. Okay, very good. Well, thank you so much for coming today. I really appreciate it, and I look forward to collaborating more with you.
Thank you. Thanks a lot for having me here today.